Hi everybody, my name is Megan and I wanted to share with you information on medications used for rapid sequence intubation, as well as the role that a pharmacist plays in this very common emergency department procedure. By the end of this presentation, I would like for you to be able to describe the process for rapid sequence intubation, identify the drug of choice in different patient populations, describe the role of the pharmacist in RSI, and identify patients who would benefit from post-intubation sedation. Let's start with the definition of RSI. RSI is the technique of concurrently administering a potent sedative agent and a neuromuscular blocking agent for the purpose of successful endotracheal intubation. RSI is the cornerstone of emergency airway management. The decision to intubate a patient is not always an easy decision, but every patient who is intubated will have at least one of the 5 following indications. They will be unable to maintain their own airway, unable to protect their airway against aspiration, unable to ventilate properly, unable to oxygenate properly, or their provider anticipates that the patient is currently on a worsening course that will eventually lead to respiratory failure. Since RSI is done in an emergency situation, it is important to have a distinct set of steps to follow to ensure successful airway management. The way this is done is by using the 7 P's of RSI. The preparation step is the very first step. This is where all providers are ensuring that all needed equipment is gathered. This is going to include equipment for backup plans if intubation was not achievable. This is the step where, as a pharmacist, you would look into the patient's history and their situation to come up with a plan on the best induction and paralytic agent for that patient with the provider. Once the decision is made on agents being used, you would calculate the dose and then draw them up. This is also where you would start to think about pre-treatment as well as post-intubation sedation for your patient. The next step is pre-oxygenation. This step is really important for patients who present already severely hypoxic, but it's also important for all patients. This step builds a reserve of oxygen that allows providers time to place that endotracheal tube. Pre-treatment is a step that is not done for all patients. We will go into pre-treatment options in the next following slide. Step 4, paralysis with induction. This is where medications are going to be provided to the patient to put them in a state that makes intubation easier for the provider and more comfortable for the patient. Step 5 is where protection and positioning occur, and that is when the provider is making sure the patient is in an optimal position for intubation. Step 6 is where the placement of the tube is done, and then an X-ray is done to provide proof that the tube is in the correct location. And the final step, or step 7, is post-intubation management. This is where you're thinking about sedation, analgesia, and paralysis as indicated. As mentioned before, pre-treatment is another step where pharmacists can be involved. Not every patient is going to require this step. So the goal of pre-treatment is to attenuate the negative pathophysiologic response that is caused during intubation. The process of intubation stimulates both sympathetic and parasympathetic nerves that are located in the airway. This causes a release of systemic catecholamines, which can increase your heart rate by about 30 beats per minute, your MAP by 20 to 25 millimeters of mercury, as well as increase arterial wall shear stress. The placement of the tube itself can stimulate the upper airway reflexes. This can include the cough reflex, can cause laryngospasm, as well as lower airway bronchospasm. It's important to remember that if it is decided a pretreatment medication will be used, you must give it time to circulate in the body. So you want to make sure that it's given at least 3 minutes before induction. Historically, a mnemonic has been used, LOAD, that includes lidocaine, opioids, specifically fentanyl, atropine, and defasciculating doses of neuromuscular blocking agents. Current evidence really only supports the use of lidocaine, fentanyl, and in very few instances, atropine. The first pretreatment medication that we'll discuss is lidocaine. So lidocaine's mechanism of action is that it's an amide anesthetic. The dose that is used for pretreatment is 1.5 milligrams per kilogram. Possible benefits for lidocaine are a little controversial. The first benefit is that it potentially can prevent rise in intracranial pressure. So as we know, coughing increases ICP, and when placing an endotracheal tube, the coughing reflex is potentially stimulated. So the theory behind the use of lidocaine is that it blunts the coughing reflex, which would prevent the increase of ICP. As mentioned before, the data behind if lidocaine actually does this is conflicting. But for now, lidocaine has been shown to be safe when suppressing the cough reflex, which is why in patients who already have an elevated ICP, like patients who have had head trauma, lidocaine can still be an option for pre-treatment. Other benefits include reducing bronchospasm in reactive airway disease. The data is conflicting for this as well, but it can still be used for pre-treatment in RSI. Contraindications to the use of lidocaine include severe bradycardia as well as severe heart block patients. Fentanyl is going to be the second pre-treatment medication that we discuss. Its mechanism of action is that it is an opioid receptor agonist. The pretreatment dose of fentanyl is 1 to 3 micrograms per kilogram over 30 to 60 seconds. Fentanyl has a couple of possible benefits. The first one being that it does provide some analgesic properties. The second possible benefit is that it potentially can blunt the effect of catecholamine release. So this is its primary role in pre-treatment, and this is to protect patients who would be adversely affected by the catecholamine release that occurs during intubation. Those who are at most risk include patients with an increased ICP, patients who have ischemic heart disease, intracranial hemorrhage, cerebral or aortic aneurysm, or patients with major vessel dissections. Contraindications to the use of fentanyl in pre-treatment include patients who have decompensated shock and patients who hemodynamically are just unstable. Lastly, we will talk about atropine and defasciculating doses of NMBAs. So atropine historically has been used to prevent bradycardia in pediatric patients. The theory is that succinylcholine, when used for paralysis, causes stimulation of muscarinic receptors. This stimulation can cause bradycardia, which seems to happen more frequently and more severely in pediatric populations. That is why historically atropine was used as pre-treatment for pediatric populations undergoing RSI with the use of succinylcholine. There really isn't a whole lot of data to support the routine use of atropine, but it can be considered if pediatric patients or adult patients are experiencing bradycardia during RSI. Defasciculating doses of NMBAs historically have been used to decrease the side effect of fasciculation caused by neuromuscular blocking agents. The theory is that when given a depolarizing NMDA like succinylcholine, that initially will cause a spontaneous contraction of the muscles in the body. This is thought to cause a rise in intracranial pressure, and so the theory was to give 10% of the dose needed for paralysis using a non-depolarizing NMDA to prevent the fasciculations that would be caused by the paralytic dose of the depolarizing NMDA. There really is not any data behind the use of this as pretreatment, and it is no longer recommended during RSI. When providers have gathered all necessary equipment, all medications are drawn up appropriately, and the patient is pre-oxygenated, so everybody is ready to start RSI, induction is the next step. So the goal of induction is to provide an amnestic state for the patient. It's important to remember that when you give a paralytic, the patient will essentially be frozen in their own body, unable to move, but able to hear and see everything going on around them. It's also important to keep in mind that they're also able to feel pain in this state. So an induction agent induces an amnestic state so the patient is not able to remember hearing, seeing, or feeling anything during intubation. The pharmacist plays a significant role here, not only assuring the right induction agent is being used and is dosed correctly, but also making sure that the induction agent is being used first. It is important to give an induction agent immediately before a paralyzing agent. Ideal agents would have the following properties. They would provide rapid loss of consciousness, provide amnesia, provide analgesia, as well as have a very stable hemodynamic profile. Etomidate is the gold standard for induction agents. Its mechanism of action is that it's a GABA agonist. GABA is one of the body's inhibitory neurotransmitters that is responsible for calming nerve impulses in the brain. So by stimulating GABA, you're producing a sleep-like state in patients. The dose for induction is 0.3 milligrams per kilogram. Typically, though, if a patient is greater than 70 kilos, you can use a standard dose of 20 milligrams for the patient. Etomidate has the property of just amnestic, so it does not provide any analgesia, but it does provide that amnestic state. Its onset is very quick at 10 to 15 seconds, and its duration is also pretty quick, so 10 minutes. Etomidate is considered the gold standard because its effects on hemodynamics is neutral. So this means that it does not cause swings in blood pressure and heart rate in either direction. Some common side effects, though, are monoclonic jerks. Some other things that you need to consider when choosing etomidate is that it has been shown to cause adrenal insufficiency, and the effects could last up to 24 to 48 hours. Some clinicians will advise against using etomidate in septic patients for this reason. However, others will still use it and then supplement the patient with stress dose corticosteroids. Thus, the use of etomidate for septic patients is provider dependent. It also has been shown to increase EEG activity in an actively seizing patient. There are some studies that show that it potentially could lower the seizure threshold for a patient with seizure history, but it's not quite as important to consider if a patient just has a seizure history compared to a patient who is actively seizing in the trauma bay. Ketamine is the next induction agent that can be used during RSI. Its mechanism of action is that it's an NMDA antagonist. NMDA is a glutamate receptor. Glutamate is the brain's primary excitatory neurotransmitter, which does the opposite of GABA. By inhibiting glutamate from binding to NMDA, you're producing the same effect as seen when you stimulate GABA. The dose for induction is a range between 1 to 2 milligrams per kilogram. The typical dose, though, is usually 1.5 milligrams per kilogram. One significant benefit of ketamine is that in addition to its amnestic properties, it also has analgesic properties. It also has a rather quick onset of 30 seconds and a short duration of 10 minutes. Its hemodynamic and respiratory effects are not as nice as etomidate, so it can cause hypertension as well as some tachycardia in patients. But one benefit is that it can cause bronchodilation. This could be beneficial for patients with reactive airway disease. Some common side effects include nystagmus, which is a wobbling or shaking of the eyes while a patient is in the amnestic state. Emesis is another common side effect. Things to consider is that you want to avoid it in patients with cardiac conditions. This is because ketamine increases blood pressure and heart rate, which increases oxygen demand for the heart, and also the shear force at which it flows. Ketamine should be avoided in patients with cardiac conditions such as myocardial infarction as well as aortic dissections. Ketamine can also cause hallucinations when wearing off. This is called reemergence syndrome. Midazolam is the third agent that can potentially be used for RSI. Its mechanism of action is that it is also a GABA agonist. The dose for induction is a 0.2 to 0.3 milligrams per kilogram dose. It has a couple unique properties compared to the other agents. It provides amnesia as well as anxiolytic effect, which means that it reduces anxiety, and it also is a muscle relaxant. The onset and duration, though, make it not very favorable for an induction agent. Its onset is between 60 to 90 seconds, so it's important to make sure your provider knows how long this will take as an induction agent. And then the duration is much longer, between 15 to 30 minutes, depending on the patient. Its hemodynamic and respiratory effects also make it not a very useful agent for induction. It can cause hypotension and tachycardia, as well as cause premature respiratory depression, which is not an ideal effect when trying to prepare a patient for intubation. Things to consider is that it's basically not commonly used for induction due to the longer onset of action compared to other agents, as well as its hemodynamic and respiratory effects. Propofol is the fourth and final agent that can be used for induction in RSI. Its mechanism of action is that it is a GABA agonist. The dose for induction is a 1.5 to 2.5 milligrams per kilogram dose. As far as action goes, it only provides the amnestic properties. Onset and duration, though, are pretty desirable when talking about propofol. Its onset is 10 to 15 seconds, and its duration is 5 to 8 minutes. What makes propofol undesirable for intubation is its hemodynamic and respiratory effects. It can cause severe hypotension, so it's important to not use propofol in patients who are hemodynamically unstable or in patients who present with low blood pressure to begin with. It also can cause respiratory depression, which, as mentioned before with midazolam, is not an ideal situation when you are trying to prepare a patient for intubation. Things to consider is that since it is a lipid formulation, you want to make sure the patients do not have a soy or any egg allergies. The following is just a summary slide of all of the induction agents. It lists the mechanism of action, the dose used for intubation, its onset, its duration, as well as key points to remember about each agent. Neuromuscular blocking agents are the medications that really set the physician up for an ideal situation when performing RSI. The goal of an NMBA is to paralyze skeletal muscle by blocking impulse transmission at the neuromuscular junction. So basically what we're doing is we're blocking the muscles in the neck from contracting and fighting the intubation process. This is going to allow the provider to perform a smooth intubation. NMBAs are given immediately after induction to facilitate ideal conditions for intubation, as well as to minimize the risk of aspiration. It's important not to delay the administration after induction agent. This is because, as mentioned before, those induction agents only work for a short period of time. So if your induction agent wears off, you risk the patient becoming aware of the situation but still being paralyzed. If there is a pause before giving your paralyzing agent, it's important to keep in mind what time the induction agent was given so you can re-bolus the induction agent if needed. There are two different classes of NMBAs. Depolarizing NMBAs, such as succinylcholine, stimulate the acetylcholine receptors that allow depolarization to occur. This allows voltage-gated sodium channels to open and then close, which then become inactivated. In order to reactivate the sodium channels, the membrane potential must be reset. Depolarizing NMBAs, though, are not metabolized by acetylcholine esterase, so this causes prolonged activation of the acetylcholine receptor, causing the sodium receptors to remain inactivated. This then causes the muscles to become flaccid. As mentioned in the pre-treatment section, fasciculations are often seen with these agents. This is due to that initial depolarization phase. Non-depolarizing NMBAs, such as rocuronium, antagonize the action of acetylcholine in a competitive manner at the postsynaptic nicotinic receptor, which prevents depolarization from happening at all. They don't produce a conformational change in the receptor like the depolarizing NMBAs do. Succinylcholine is the gold standard when it comes to paralyzing agents in RSI. As mentioned before, its mechanism of action is that it's a depolarizing NMBA. The dose for induction is a 2 mg per kilogram dose, and its onset and duration is actually what helps make it the gold standard. So onset is about 45 seconds, so it's pretty rapid, as well as its duration is shorter, 10 to 15 minutes, which matches pretty nicely with the duration of the induction agents that we previously talked about. Things that make it not quite as desirable are the fact that it can cause hypotension as well as bradycardia. So it's important to consider these properties when deciding which paralytic agent to use for your patient. Other things to consider is that it can increase potassium. Typically, this is only by about 0.5 milliequivalents per liter, But in patients who are already at risk of hyperkalemia, it can increase this up to 5 milliequivalents per liter. Patients at higher risk for hyperkalemia include patients who are coming in with a crushing trauma, patients who are on hemodialysis, patients who have been in a long code, and patients who are currently in status epilepticus. You also want to avoid it in patients with a history or family history of malignant hyperthermia. Rocuronium is the second agent that can be considered for paralysis in patients undergoing RSI. As mentioned before, its mechanism of action is it's a non-depolarizing NMDA. The typical dose is a 1 milligram per kilogram dose. Onset and duration are what make it a little less desirable in most patients. Onset can take up to 60 seconds, and the duration can last 40 to 60 minutes, which does not match up nicely with the induction agents that we previously talked about. One thing that is very important to consider with rocuronium is that you need to start thinking about post-intubation sedation as soon as it's decided that this is the agent that is going to be used. Things that make it very desirable, however, are that its hemodynamic and respiratory effects are neutral. So with this, some providers will prefer its use due to the lack of major adverse effects, such as hyperkalemia and the malignant hyperthermia. Things to consider, though, as we mentioned before, is that the duration is much longer than succinylcholine, so it's important to start thinking about that in post-intubation sedation for your patient. This is just a summary slide on the differences between the two agents, just like the induction slide. So we have the mechanism of action, the dose, onset, duration, and key points for consideration when deciding which agent to use. Post-intubation sedation is important for all patients. The goal is to provide a continued sedation after intubation to prevent post-intubation complications. So RSI is being done in a very fast-paced environment, and even though it is not an invasive surgery, there's still the risk of damaging the airway during the process. When your initial sedation and paralytic wear off, the patient could be in pain from this procedure or their current injuries that they came in with. The other thing to keep in mind is that the patient now has a tube in their throat, which is not the most comfortable situation, which can cause restlessness and even fighting of the ventilator. Post-intubation sedation keeps the patient in a calm state in which the ventilator can do its job of breathing for the patient, as well as provide the patient a level of comfort while in this situation. Post-intubation sedation is most important in patients who receive a paralytic without induction and in patients who receive rocuronium. But, like I said before, it's still important to consider in all intubated patients to maintain that level of comfort and avoid the risk of self-extubation. Agents that can be used are your propofol. So you want to make sure that the patient is hemodynamically stable enough to receive propofol, and this is due to the side effect of hypotension. Propofol is a good option if neurologic functions needs to be assessed due to its very short duration of action. Typically, you'll start a continuous infusion between 5 to 70 micrograms per kilogram per minute. Typically, though, most patients get started at a 20 to 30 microgram per kilogram per minute dose, unless they are a little more hemodynamically unstable. Benzodiazepines are also good to use in patients for post-intubation sedation, and you'll typically use these when a patient cannot tolerate the propofol drip, or in patients who you do not need to assess the neurological function quickly after intubation. You want to make sure you're avoiding its use in patients with hepatic failure, and in that case, if you do have a patient with hepatic failure, lorazepam is preferred over midazolam. Typically, benzodiazepines are given as a bolus. Midazolam, since it's a little bit shorter acting compared to lorazepam, typically needs about 2 bolus doses after receiving rocuronium to keep the patient nice and calm while that paralyzation is wearing off. Lorazepam is a little bit longer, so typically in that same situation, you only need about 1 bolus dose. It is important, though, to remember potentially the patient might need more, making sure that the provider has a correct order in so the patient can remain comfortable and allow the vent to work. Thank you for spending some time with me today to talk about rapid sequence intubation. Pharmacists play a very important role in ensuring the right medications are being chosen, the right dose is being used, as well as the right sequence of drug administration is being performed. This process is typically in a very high stress situation, and it's important to be able to recall the subtle differences in these agents to ensure a smooth intubation process for all of your patients.